You know, I think there's no doubt that the way the future looks for IBD care has been so beautifully depicted by these docs, where the one thing that I would add is it's going to be a blend going forward. We're still going to need to see you. We're still going to need to wrap around you and make sure you're well. So one of the things that I think challenges us the most is, how do we identify who needs to be seen? So certainly we need to think about the economics and the logistics of seeing you and making it safe. And what we did in Calgary really was we looked at a couple of system models and came together as providers with two main purposes. First and foremost, as has already been outlined, keeping everyone safe, both the patients and the providers safe. And in that, we knew what we wanted to do was avoid patients unnecessarily coming to emergency departments and requiring endoscopic evaluation when we could look objectively at your disease activity in another way. So what we did as a system was, number one, we centralized our processes. So we brought together a mechanism so that patients, more than 5,000 patients in our clinic, could access one phone line and one email access line, which was really the brainchild of one of our most accomplished nurse practitioners in Canada, Joan Hetherington, in addition to IBD fellows who screened patients who were filtered through this one single point of access. And then we could very easily identify when patients were flaring based on a combination of blood work and their symptoms. In addition to that, because we've got a blended system in Alberta where we have some docs who are academic and they're paid by the university and other docs who are private, we wanted to make sure all patients in our Calgary zone had the same access to care. So we ensured that through a centralized model, if private docs who weren't able to see their patients face-to-face could then send a referral through our central system so that we could then say, here is a patient of Dr. X who's in a private clinic. We need to see that patient here in our centralized model. And what we offered that patient and that physician is a combination of both invasive and non-invasive tools. So we have access to outpatient, non-sedated, flexible sigmoidoscopy. So if you have ulcerative colitis, we can easily, very safely outside of the hospital system, provide endoscopic assessment where appropriate. And the second thing is we provide very safe and screened lab services. So we can do a fecal calprotectin or a poop test to see if you've got active disease. And secondly, blood work. So this is beautiful. Thank you so much. I'll just keep going. If you can go actually down to the third slide. Perfect. So Gil Kaplan this is just a quick other systems comment where Dr. Kaplan is actually the scientific director of our digestive health SCN. And this was a province-wide coordination collapse of services so that we could coordinate care. Next slide, please. So importantly, as has already been outlined, when we think about our priorities and our values, we want to make sure that we select the patients that need to be seen face-to-face appropriately. Next slide, please. So what we did, as has been described so beautifully, is we provided and continue to provide virtual access, robust virtual access. But in addition to Zooming or video conferencing patients and calling them, we also allowed them to access our centralized process and then provide that service across the Calgary zone that has about 1.3 million patients. Next slide, please. So again, in this clinic, we have a number of tools that we can utilize to keep patients out of the emergency department, out of acute endo. Next slide, please. And these are the very clever folks who I work with who help to create the clinic and provide the services. We have 2 IBD fellows, both who are training in intestinal ultrasound. My good friend and colleague, Dr. Kathy Liu, whom, like myself, has an academic and a clinical interest in intestinal ultrasound. And we had centralized booking so that we could be consistent and robust in our selection of patients who we needed to see in clinic because they were ill.